All right. So I think we're going to get started. If everybody might have a seat and tune on your online. If you're online, I know we have a fairly large number of people online. And for those of you online, we have a large number of people here in the room in person who are enjoying the last of their sandwiches. So glad that you were able to join us. For those of you who don't know me, I'm Deborah Marshall. So I'm a professor here at the University of Calgary in Health Services Research and Health Economics. But today, standing here, I'm wearing a different hat, and that is with respect to my role at ISPOR, which is the Professional Society for Health Economics and Outcomes Research. And I have been reflecting, obviously, given our guest who's joined us, whom I'll introduce in a moment, about my journey in ISPOR, which actually has been rather long, and I've decided I'm not actually mentioning any dates so that we don't date myself. But I've been involved with ISPOR for a long time. And currently, one of the hats I wear at ISPOR is the chair of the Health Science Policy Council. And notice the two key words in that, science and policy. And the other bits are health, of course, and council. So I'm actually very excited and feeling very privileged to be in this role. ISPOR has really grown over the years. And while it's been a rather influential and large organization for a long time, it's actually now an 18,000 member organization worldwide. So it's not trivial, and also has considerable influence. And one of the things we've been talking about a lot, and this permeates everything we do as a researcher. I've worked in many other areas as well, but as a researcher, it's about how do we have impact? And it's hard. And we need to partner. We need to have relationships. We need organizations that can bring the expertise to bring our insights from our research into practice if you want to have influence and make change. And I know I do, and I hope all of you do too. So we recognize that that's very important. I was also given pause to reflect on the critical importance of mentorship and learning and sharing. And this was highlighted repeatedly in our discussions over dinner last night, where we had some of our students join Dr. Pizzi and myself for dinner. And I was reminded that I came to be involved with ISPOR through people who were my mentors. And many of you may know Dr. Bernie O'Brien, who was my mentor, and Mike Drummond, who was also my mentor and continues to be my mentor. They recruited me back to Canada from the US. And for those of you who work in health economics, they wrote the Blue Book. So very influential internationally and continue to be. We still use those textbooks. Every health economist I know uses that as a textbook in our health economics class. And so I've had the privilege to have amazing mentors through my career. And part of what we want to do is to share the ISPOR network opportunities with you, where you can engage, I think, in many different levels, way beyond health economics. I will say ISPOR is not just health economics, although health economics is absolutely critical, but it's so much more, and it's got a really big policy footprint now. So I think this is very exciting for me. The other hat I wear has been I was reminded this morning in our conversations, again, with the Health System Impact Fellowship. And one of the things I said virtually at the beginning of every one of our annual retreats to our Health System Impact Fellows is, it's all about the network. You need to really work at your relationships and your networks, because this is how you can go far and have big impact. So I'm very excited about that as well, because we had the opportunity to do the training for the Health System Impact Fellowship being led by the University of Calgary. And I watched, 50 postdoc, PhD students be embedded in experiential learning in health system organizations and try to make real impact. And I think where we integrate research and policy and implementation is really where we can make a difference. So it's my thrill and pleasure to have Dr. Laura Pizzi come from ISPOR and visit us up here in the frozen north, as I've been teasing her all weekend, and take the time to share with us. So I'll just take a moment to tell that ISPOR, as I said, is large, very influential, and her role, believe it or not, is massive. Is much bigger than one might think. And it's really providing the strategic scientific leadership in ISPOR and really overseeing our major initiatives like the science strategy, which involves people from every country in the world practically, and very influential academics, but also policymakers and organizations like the WHO, EMA, European Medical Association, the Food and Drug Administration, all of the above. So there's a really tight connection there. And what you might also be very interested to know is not only is that the role of Dr. Pizzi now at ISPOR, but she spent 25 years in academics at Rutgers University and was very involved in research in chronic diseases and implementation strategy, vaccines, chronic disease, lung disease, et cetera. So she's really brought many worlds and views to this whole thing. So I think there's lots to learn. She wants to continue learning. That's why she says her job is fun. And the whole idea of her role is really to bring the science and the policy and the influence together on a worldwide basis. So I'm absolutely thrilled to welcome her here today. And she's not going to come up yet. She's going to pop up in a moment. But what we're going to do is, of course, I will talk and acknowledge that we are on the lands here at the University of Calgary in southern Alberta, and it's the lands of the peoples of Treaty 7, which are unceded territories, and it involves a large number of territories and peoples of different nations. And we also host the lands and are home to the Métis Nation as well. And Laura and I had a chance to be up in the beautiful mountains yesterday and enjoyed other lands of other territories and other nations as well. So thank you, and we're grateful to be here. So before we get started with Dr. Pizzi's talk, I want to introduce you to our enthusiastic ISPOR students and early career researchers who are student members of ISPOR, but also, I guess, sharing with you their enthusiasm for being part of ISPOR and the benefits, I guess, that it brings to ISPOR. So I'm just going to have all of them stand, and then I'll invite Nihal. So where did Angelina? Oh, there she is. Angelina Ade, who is considering and being the proposed student chapter president, and Nihal Amin, who is proposing to be the secretary of the proposed chapter, and Mohammed Rahan, who is also here as the treasurer proposed. This is what they're thinking and planning and plotting. And where did Sandeep go? Oh, there he is. And right by there, sorry. And Sandeep, who has been serving in the role of vice president. So they want to share with you their experiences. Most of them have been at ISPORs and know what the benefits are and are inviting you to become part of this as well. And with that, please, Nihal, if you could join me, and she's just going to walk us through some of this. So are you okay? Thank you.
All right, so welcome everyone. Before we start, just a quick show of hands. How many of you have heard about ISPOR before today? Impressive, right? So that's actually, yeah, I know. It's perfect, but whether or not your hands were up, I just want to tell you in the next few minutes, we will be talking about ISPOR, what HEOR means for a career, and what are we trying or plotting or cooking in the background for U Calgary. So without further ado, just as our agenda for today, talking about ISPOR, our student chapter, who can join and why should they join, our mission, and how to contact us. All right, so just starting off, just like Dr. Marshall mentioned, ISPOR stands for International Society for Pharmacoeconomics and Outcomes Research. It's the global home for HEOR, which is Health Economics and Outcomes Research. And you're thinking about HEOR, I knew this would happen. You can just think of it about answers about what treatment, if treatment actually works, it works for whom, and if it's actually worth it or not. And also, like, if you are in health science, economics, stats, nursing, or a policy, this discipline makes real decisions about real patients. And in ISPOR, this is where the conversations are happening globally. Looking at ISPOR's vision, we have that it's a world where healthcare is accessible, effective, efficient, and affordable for all. For our mission, we are advancing HEOR excellence to make that happen globally. And for our 6 values, we have transformative, scientific, inclusive, collaborative, transparent, and ethical. And all these are the same values that we are being trained in our programs to introduce into our own research. Okay. All right. So if someone decided to join ISPOR as a member, what benefits they can get out of it? So we have world-class global scientific conferences that you can join. Midline publication, yes, these are the ones that we are citing in our research papers. Also, we can have hands-on HEOR tools and resources, training programs, career development support that would look so good on your CV. And practically, a membership is a direct line with researchers and decision makers that are very close to shaping the field. And that's why we were thinking about reviving the student chapter here at U Calgary. The chapter existed like a couple of years ago, but now we're trying to revive, we're working on reestablishing the chapter one more time. And like, for example, like what will come out of this membership or why would you care to join? It's not joining ISPOR is not just a global membership, which is powerful, but having a local chapter makes it real. Think journal clubs, workshops, case competitions, even events like today. These that can help you be exposed to the industry, to the field, and knowing what to do next with your career. We even have one student that shared before that joining gave them experience and global connections that they couldn't have gotten any other way. So let's talk demographics, again, like any other research paper that we handle. For ISPOR, the student network is over 1,500 members, represented in 70 plus countries. And we also have 90 plus chapters worldwide. So joining U Calgary's chapter means joining a global movement. And then I'll hand it over to my colleague Angelina, who will walk us through our team and our 2026 vision. Thank you.
Thank you, Nihal. So the plan is to walk you through what started in October 2025, where we are now, and what we want to achieve moving forward. And so we had an initial meeting in October of 2025, and we're discussing to set up ISPOR student chapter. And a few of us came together and we were excited to be executives. So we formed a proposed executive team. And with the help of our faculty advisor, Dr. Deborah Marshall. So we also reviewed our ISPOR chapter constitution and agreement requirements. And right now, the stage we are at is an institutional review. So going through the University of Calgary's administration. And then hopefully we would officially launch the chapter. And then it will be recognized within the University of Calgary. So that's the plan moving forward. And Dr. Marshall introduced us, so our names are here, but this is the key part. Why should you join University of Calgary chapter? And a lot of people actually approached me and then they were asking, what is ISPOR? Do I belong in ISPOR. And so this is a list. It's not exhaustive, but if you're in the biological sciences, biostatistics, data science, epidemiology, economics, health policy, health services research, if you're pursuing an MBA, if you're pursuing nursing, public health, any other research or program area where you impact patients and the health care of patients, you're invited to join ISPOR. And if you join, you get a variety of support. So we're looking at industries in clinical trials, in evidence generation, patient-reported outcomes, economic evaluations, modeling, access strategy, statistical analysis, policies and guidelines. And actually, ISPOR has one of the top affiliated journals. So if you're a student or a researcher, it's a high-impact journal, the Value of Health Journal, that you would want to publish or present your research on. So these are some of the activities that we hope to begin. We're ambitious, so we're looking at having 50 active student members by the end of this year. The year is not over, so we're still going to meet it. And then we would host an annual seminars on health economics. We would conduct hands-on workshops in health outcomes research, and we would also want to host faculty-led sessions. We would also want to invite industry experts and faculty lecturers and have like an informational interview, journal discussions, and a mini student HEOR conference. So I know Dr. Pizzi will talk more about it, but then ISPOR hosts a global conference. And so the plan that we had is to also conduct like a mini conference. If you have a research in progress, you would have the opportunity to present it. Then one of the most important things that I am really passionate about is setting up a job board and having internships, posting job ads, internships, and also inviting industry experts on what are the soft skills that you need to be able to get a job after school. Then we would want to partner with other universities, so other ISPOR chapters. So I know in Canada we have UBC and then University of Manitoba. And so University of Calgary would want to do some collaborative activities with them. So please follow us. We have a LinkedIn page that we plan to launch potentially today. And also we have an email if you are interested. If you have any question, please follow us. If you can also approach me if you have any questions about ISPOR, joining, becoming a member, any kind of question that you have, please, feel free to approach me or any of the executive members. Thank you.
Yes. Thank you so much, Nicole and Susanna. Absolutely lovely, and I really love the enthusiasm. So now,
Ready?
invite Dr.
Thank
Pizzi.
you, thank you. Thank you so much for that warm welcome, and I swear I didn't pay them to say all those nice things about ISPOR. But I'm truly honored, and I feel so welcome here, partially because I spent so many years in academia, but also because I feel a lot of kinship with respect to where ISPOR is going as an organization and the interests of the research students and faculty that I've talked to so far here today. So thank you so much to Deborah for hosting. We did our own little stampede yesterday. We stampeded on the snowshoeing trails. That was a really bad joke. Okay, so, and I do appreciate the opportunity to learn. I'm not here to talk to you just about what ISPOR is doing, but this is like a reconnaissance mission for me. I like to hear what's happening locally and take that back to help inform our initiatives moving ahead. So I won't say as much about ISPOR given the exceptional overview we had from Nahal and Angelina, but I do want to spend a little time talking about global trends in evidence development, and I'll kind of close out with some thoughts about broadening our understanding of value through this strategic theme we're calling whole health. So briefly, I won't say too much about HEOR because I know the folks here are familiar with it. I will only say that the field has become broader and broader and broader over the years. In fact, When I first joined ISPOR, believe it or not, in 1996, it was almost all HE. And at that, it was more pharmacoeconomics, not really health economics, looking at other interventions, more broadly. And then over the years, as we started to learn more about PROs, and outcomes research instruments, that became validated, and patient preference science, started to evolve. And by the way, the real world evidence movement took hold, that actually the OR side of ISPOR started to grow. And the ISPOR today actually is more about the OR than the HE, only because more of our members are actually working on outcomes research related science than health economics. But yet at the end of the day, those two fields need to come together to shape our understanding of value. So just quickly by the numbers, we're 30 years old. We have over 10,000 people come to our conferences every year. We get about 6,000 in Europe and around 4,000 at our North American conference. Each scientific program committee that my team manages has between 400 and 500 scientist volunteers reviewing around 3,000 research abstracts and around 350 session proposals. We actually have an 80% rejection rate on our sessions because we get such an enormous volume, and it really does take an army. Getting involved in the program committee is a great experience. If anybody here is interested, let me know, because it's a good way to learn what other people are doing, but also it's a nice way to learn about ISPOR and maybe learn what might be a good next step for you. We have 3 journals. I'll tell you about them in a little bit. We currently have 77 full-time staff. Our headquarters is in central New Jersey in the Princeton area. 14 of them are on my team, the Science and Health Policy Initiatives team. And then we have multiple stakeholders. Our sandbox has different kids playing and making different shapes. And I'll tell you about who those stakeholders are. It's one of our greatest strengths. It's also one of our greatest challenges. Ultimately, we need to have multi-stakeholder approaches, because if you just develop evidence, then how do you know that evidence is actually going to be helpful to this decision, or that it's actually going to be used? And this multi-stakeholder approach really does make ISPOR unique. I mean, if you go to a typical ISPOR conference, you'll see that our panels commonly have a regulator, a scientist, maybe the HTA authority, or a patient rep, sort of talking together, giving different lenses of the same issue. We have, I think it's 19,000 members globally. We're in over 100 countries. The data that were shown before were just where we had the student chapters. And my team generates around 5 to 10 scientific reports per year, all powered by our fantastic volunteers. We don't write these reports. Our scientists do. And Dr. Marshall has been just an exceptional example of that with all of her patient preference work, which, by the way, those reports have been widely cited and well before their time. Because now we're in an era where FDA had come out with patient preference guidance, and EMA, and now I hear ICH is coming out with it. So our patient preference reports, we're ahead of the game on all this, which is fantastic. You've seen the vision before from Nahal. The only thing I'll say is that in our strategic plan, we also have 3 major themes that were tagged as shaping the future of healthcare in the next 10 years. One is affordability of healthcare worldwide. The second is digitalization of health. And the third is this idea of whole health and well-being. And these themes are really coming through in our strategic plan and driving a lot of the member activities and programming that we have at our conferences. So this is our global footprint. As you can see, we are very much around the world. Historically, we've had a larger membership representation in North America. Europe is second to that. Around 20% of our members come from there. And we're growing. We're growing in emerging parts of the world. And we have a rather, I call it newer interest in Asia Pacific being a focus. We held a summit in Tokyo last September, and this September we'll be in Bangkok, focusing on access and affordability in the Asia Pacific region. And increasingly interested in Africa, as they've had African Medicines Agency, African CDC, et cetera, evolving, and have some, I'll call it light activity there, mostly involving the Gates Foundation and capacity building. So this is our stakeholder map. Like I said, this is the sandbox. We have mostly researchers and academicians making up our membership base. We have regulators increasingly in HTA bodies. We have payers there as well. We have not had as many policymakers, if we think of those as government officials, although we're getting more into that space. Life sciences industry as well, so sort of the supportive functions that take the evidence and package it for the decision makers. Healthcare providers, although we haven't really focused as much on that audience, we hope to moving ahead. And importantly, patient engagement organizations. We have a very robust patient council. We do patient roundtables with patient reps from different parts of the world to advance patient engagement in science. New is investors. We had a breakfast at JP Morgan. We presented at Davos last year. We have a investor summit coming up in San Francisco in September. Why are we getting in this space? Because investors are realizing that unless you have solid evidence, either A, no one's going to want to buy your innovation when you're ready to sell it off, and or B, when you get it to the point of regulatory and HTA decision making, you might not have all the data you need. And very interestingly, the investors are super interested in patients, engaging patients early. Actually, we hear that more from the investors than we hear from all the other actors in the system, which is just some little trivial tidbit that might interest you. We collaborate with a lot of organizations, but we don't have the resources to collaborate with everybody who would like to. It's based on alignment with our strategic plan, really. And these are more focused on the scientific partnerships. I'm sure other parts of ISPOR would have a slightly different set of boxes. So I do a lot of work with ISP. We have a designated rep of ISP, the International Society for Pharmacoepidemiology. There's a joint task force we've had the Harper template with ISP. We have a new one on RWE feasibility assessment with ISP. And we're developing a joint commitment to transparency for real-world evidence studies that will be co-signed by ISP. We have a series of task forces done with Society for Medical Decision Making. We have one going right now on model validation approaches. We have a formal memorandum of understanding with EUPATI, European Patients Association, based in Brussels. And they do training and capacity building for patients, not only in Europe, but they're starting to franchise out in Asia, most notably. We have an MOU also with World Health Organization Europe. It's about mostly HTA capacity building in Europe, which you may say, well, wait a minute. There's already the EU HTA regulation, and there's a great HTA infrastructure. That's in Europe. But who Europe serves is also the border states to the EU, along the eastern fringes of the EU predominantly. So their stake is different than the European Union, and they're very interested in building capacity in those border states, which, by the way, tend to be lower income and tend to have lower know-how regarding HTA. Sadly, who has also been badly hit by cuts to science, cuts to their funding, but thankfully our MOU has prevailed despite the disruption. EMA is one of the partners that I spend a lot of time with. That's the European Medicines Agency in Amsterdam, bridging sort of the gap between their regulatory needs and our ISPOR member initiatives, bringing them into things like our RWE task forces as a member, bringing them into things like our conferences, et cetera. Duke Margolis in Center for Health Policy is very involved in our real-world evidence initiative. I mentioned Gates, and there on a day-to-day basis there are more, but there has to be a solid reason why. There has to be some clear, as I said, product or deliverable that is strategically relevant to both parties. We have 3 publications. 2 are peer-reviewed, Value in Health and Value in Health Regional Issues. Value in Health is our flagship publication. It has an impact factor of 6, which is very respectable for a subspecialty journal. It gets around 2,000 submissions per year and has an 82% rejection rate. So it's a little tough to get in, but it's solid in terms of its guidance and scientific quality. Regional issues is more about local studies and applied examples of health economics in practice. It's newly indexed in Medline, has an impact factor of, I think, around 2.0, fewer submissions, but also kind of on the rise. And then we have the Value and Outcomes Spotlight, which you can think of as our magazine, and that goes to 60,000 readers worldwide. It's more about, for people who are not into evidence, it's like a lay language summary of HEOR and issues in HEOR. We have an active call for papers in Value and Health, evidence synthesis in HEOR. If you're interested in that, let me know. I can hook you up. I'm going to breeze through this super fast. As I said, in any given year, we have a number of publications that our scientific member groups produce and publish in Value and Health. They span the whole range of HEOR. Here's a sampling of some of the ones that were published last year by our member groups. And I'm going to skip through what task forces we have right now because I want to get through to some of the more exciting things. I will only just say that if you look at the, I'll call it the scientific recommendations ecosystem, if you will, where you need to first identify that there needs to be a method on a topic, and then there's maybe some early work or emergence on it, and then maybe there's some guidance that comes forward from that, and then maybe that guidance gets harmonized across different contexts or decision makers. Our space is mostly in the boxed area of emerging, and we try to really surveil and look at what are the methods needs that are coming up that are going to be needed a couple of years down the road, and we've tried to feed those into our good practice reports, which Dr. Marshall effectively oversees as her role in Health Science Policy and Council Chair. We track uptake of our good practice recommendations around the world. This is North America and Europe. And then recently I did a little bit of this analysis for Asia and was pretty impressed by how many Asian HTA and regulator decision makers have taken up our good practice recommendations. Briefly, we're not just about doing the science, but we support the science by championing the value of HEOR. This is super relevant to students and young professionals. We do workforce surveys to understand trends in employment. We communicate thought pieces and do sessions on the value of HEOR. We have a submission category to our conferences called Impact Cases, which is about use of the science to inform a decision. There has to be a stakeholder identified. There has to be a healthcare problem identified, and explanation of how the evidence was used to address the question. We also just updated our competency framework for HEOR professionals, freely available on our website if you're looking to get a roadmap for the knowledge and skills that are associated with HEOR. Now, let's get a little bit more into the fun stuff, shall we? So I'll talk to you a little bit about global evidence trends in this segment. We publish what's called our Top 10 Trends Report. Again, freely available. This is more about awareness building, this report. It's not a scientific study. It's like a straw poll that we do every other year and our Health Science Policy Council assists with. But the purpose of it is to understand, hey, what are the trends that are popping up and really important in HEOR? It also builds awareness about our science because, this gets picked up in outlets like Politico and other, kind of regular mainstream news outlets, and it builds awareness about what is HEOR, so it has an important role in terms of basically championing the profession. Number one on our list is AI. That jumped up from number 2 last time. Number 2 is real world evidence. 3 is value-based healthcare. Value-based healthcare has never been on our list before. First time ever, and it pops up at number 3. I think it's significant because it means that in this world of HEOR, which is mostly about understanding the value of innovation, that there's a recognition that we need to understand the value of the information in the system. We have a task force now on this topic as well, value-based healthcare. So clearly there's a movement more towards understanding beyond, I'll call it beyond the pill, what are the implications of the diffusion of innovation within the system. Some of these other things, drug pricing, innovative therapies have been on the list before. Patient centricity jumped up. It was number 8 2 years ago. Relevance of HEOR was not on the list last time. It's new, enters at number 7 because of so many shifts happening in the healthcare landscape, pharma retooling its workforces, WHO and other organizations having to cut people. So the need to demonstrate the relevance of our field has never been more important. And then value measurement is here as well. Value measurement, though, specifically with a lens towards broadening our understanding of value, because that was the specific question in the survey that was administered, and digital health. So when we look at these trends by region, you can view this as kind of like a heat map, so to speak. We had 740 responses. I mean, not enormous, but enough to start taking a look at regional differences in the trends. So anything that's a dark green means it was ranked a higher priority in that region. And then as the shades get lighter, it means that it's basically ranked lower. So there's strong agreement that AI and real world evidence are important globally as major, kind of evidence needs in HEOR. And then drug price negotiation, also high on the list, not surprisingly given things like potential for US reference drug pricing, market-based approaches to drug pricing that will have global implications. Affordability pops up as well, very high priority in Europe and Middle East and North Africa, important but not as important in other regions. And then some of these ones in the middle, I won't dig into extensively. I will just talk to you a little about what I thought was interesting, which is that implementation science in HEOR came up in South Asia. Why in South Asia and the other regions, I'm not 100% clear on, except again, maybe an understanding that you need to understand what the diffusion of innovation is within the healthcare system, and maybe just the recognition might be better there than in other regions. And I'm trying to say, efficiency in conducting research came up in sub-Saharan Africa as number 6. Not surprising, probably due to low capacity in that region. Okay, so what's our vision for the future? It's great to know what's happening now, but what's our vision for the future of value assessment? Because we're all about pushing the science forward, not standing still and assuming that what we're doing today is going to work for tomorrow. The world is moving way too fast. So we envision a future where there are living healthcare assessments that are rapidly conducted using real-world data, powered by AI. Think a few clicks, click, click, click. Okay, we're going to rerun the algorithm, and it will be living in that sense. We can update our SLR within minutes, right? Or our real-world data analysis. We envision that there'll be an increasing focus on the system, given that affordability and resource constraints are a problem globally. And so this whole idea that we can continue to just look at the drug or the technical innovation in a silo is over. That era is over. We need to look more comprehensively using a system-based approach at outcomes and cost, and also expand into things like pathway-based modeling and multi-sector assessments that bring in other sector benefits and costs outside of healthcare. Transparency. We know transparency is so important to the trust in science, given where we're at with attacks on science. Transparency will become the norm. And we see this already. It started in the real world evidence movement where we've got pre-registration of protocols required. We're coming out with a transparency statement on real world evidence. But I believe that transparency will encroach upon all areas of HEOR. There's going to be an expectation that you publish your protocols, your code, your data, your instruments, where you can. We recently also started a badging process with the Center for Open Science where we now put badges for these things on value and health publications if in fact they've pre-registered through the COS portal. Expanded expertise will be required. Clearly, as our tent gets bigger, we need people like implementation scientists to be working with us, environmental scientists and others. We're in an era of increased globalization, so global standards will have increased influence and impact. And that's global standards, by the way, not country specific. The challenge now is that there are a lot of country specific guidelines, but not as much global guidelines. That is changing, and I think the best example of that is the International Council on Harmonization, a partnership between many global regulators, who is now coming out with guidance on things like real-world evidence and patient preferences. And importantly, the last little bubble there is that the evidence has to fit the context of the decision. What does that mean? Is that we can no longer assume that our model is going to meet the evidence need of the decision maker because they're battling these big problems of affordability and access. So how are we going to change that? Well, the way that we change that is rethinking the model of how we develop evidence by having, let's say, early joint consultation between the stakeholders, having, let's say, the innovator company engaging early on with an HTA authority to anticipate better what the evidence needs will be. Say a little bit about trust in science next. This keeps me awake at night, as is poor CSO. And I will just say, and I don't want to get misty about it, but never in my life did I imagine I would have to get on the big stage at ISPOR and say that I stand for science. And I had to do that last year. It was so hard because I thought it was a given. And I needed to do that because I wanted our community to know that like ISPOR stands behind you. We are a champion for science. So, your work is not in vain. We have your back. And as a professional society, we're going to continue to be a place where you can network and learn and grow and bring new ideas and guidance, best practices forward. So, but this thing about trust in science, a lot of it, I feel like the scientists that I've talked to say, well, it's all about the politics and this is horrible. We're a victim. We're a victim. I know that's partially true. And, sometimes as a resident of the United States, I'm embarrassed. I'm sometimes embarrassed by things like the anti-vax, et cetera. But why are we the victim? And I know some of it's just misinformation, ignorance, et cetera. But I do think that there are things that we can do as scientists to shift the conversation. So what do we do to shift the conversation? What is our weakness, right? And in this whole evidence game, what can we do to increase that trust? And so when I think about this a lot, I think about, my gosh, the evidence that we're generating is good, but can it be great? What great means is that it's actually answering the questions that the decision maker wants in an accurate way, and that it is consistent and reliable in terms of how we measure outcomes and costs and the assessment of value. As I go around the world and I talk to different stakeholders, HTA, regulator, et cetera, this issue of what I'm just going to call it precision, right? I'm not going to talk about validity today. I'm just going to talk about precision because validity is another topic, but let's just focus on this. The complaint that I hear is, I got the data, I got the evidence, but there's a lot of gaps in it. There's too few patients in it. It's, not focusing on the population that I'm interested in my country. It came from UK and I'm in Thailand. So this issue about making the evidence more precise for the decision maker, I think is a fundamental challenge and opportunity for us that gives us some hope in terms of how we can increase the trust in our work and the relevance of our work. I thought about this a lot, and I know everybody here is too young to know who this character is, but does anybody know who it is? Who said that? Yay! Howdy doody! Okay, so the way you can think about this is, which evidence TV are we watching? When HEOR first came out, we had models, they're largely based on assumptions, estimates, et cetera. View that as the 1950s TV, right? Which maybe happened, I don't know, 30 years ago. Then you move to the middle TV. We're in the 1990s with a big console TV, right? Well, what you see here is you could actually see Howdy Doody. Howdy Doody is the evidence, by the way, if you didn't get that part. But you can see that Howdy Doody is actually a puppet. They're strings, right? And I think of those strings as the flaws or the gaps or the imperfections, that Howdy Doody isn't this magical. Somebody's actually, there's some imperfections there. And so we're kind of in this era right now, I actually believe, where we have the evidence, but we also know what the limitations or caveats are to it. But where we're going is this super cool Samsung frame on the right-hand side here, which is a brand new TV. And this one, you see Howdy Doody is generated with CGI. He looks perfect, doesn't he? And he doesn't have any strings, because actually we want evidence that doesn't have these strings attached. It doesn't have that uncertainty. There will always be some level of uncertainty, but powered through greater real world data and AI, maybe we can get to a Howdy Doody that looks crystal clear. So, what are the threats if we don't improve evidence precision? And I do believe there's a lot at stake here. If we don't, kind of at the bottom of, end of the day, bottom line, improve, I'll just say, the quality of our evidence in informing the decision. Well, first of all, there could be misaligned decisions. If we continue focusing on average evidence, we're not going to know much about how heterogeneous patient subpopulations are changed or influenced. We will have a loss of influence as a profession. And, data scientists and analytics teams probably would be more than happy to fill the gap that we leave behind. We want those disciplines to be part of our team. We need them. We need them for computational science and analytics. But we also don't want to sort of be so stuck in our own stodginess that, we're not kind of doing things as fast as we can and leaving a gap, because they're going to be able to analyze data a lot more quickly than we can do in HEOR. They're not going to have the HEOR training, though, on things like the design, looking for bias, et cetera. And we really need to insert that, make sure we keep inserting that into the evidence conversation. And then the last thing, this is another thing that keeps me up at night, is when evidence is sidelined in policy. Right? We're now in a stage where governments are coming out with policies that don't say you need to have evidence in it. And I'm going to give the US reference pricing policy as an example of that. The Globe and the GUARD models came out probably a month or two ago, which cover this. They don't specify you need to have value assessment. They don't specify you need to have evidence. And that's scary. And that's something, it's a reason why ISPOR is now building a brand new policy function so that we can keep being a champion for science, but in a different way, like by actually commenting on things and talking to policymakers. So again, there's a lot of things that led me to think about evidence precision as kind of a main theme that we can focus on to bring the field forward. There's some trends within some of those top 10 trends that we're seeing here. I probably, in the interest of time, I'm not going to have enough time to go over all of them, but there's signals. Like, one of the cool things about ISPOR is that we're sitting on so much data and content. Like, there's signals every day that are kind of hitting us. So, we see certain things like in the real world evidence space, there's increased interest in consistency between target trial emulations for comparative effectiveness studies. We're seeing things like major funding going behind federated data sets, such as the Darwin EU initiative in the EU. Why more data allows you to answer your research question more precisely. If it's, presumably the right data, of course, but of course, having more data and more options to choose from could facilitate that. There's the badging expectations I talked about. In the patient-centered evidence space, patients are getting more and more sophisticated. They're not just advocates anymore. Many of them are actually understanding what patient experience data are and are engaging in it. we're seeing major guidance and reflection papers coming out from regulators, and patient orgs are now focusing on areas where they've been absent, like within the real world evidence space, and saying, oh my gosh, like this RWE study is not precise based on our experience. Just because it came out of a clinical EHR system doesn't mean that it's relevant to me. So I view that as related to precision, right? It's about improving RWE studies and their relevance to patients and in the system. AI, of course, AI we're seeing used across all parts of HEOR. We're seeing increased use of algorithmic-based EHR algorithmic-based EHR data extraction. The next frontier there is going to be sort of validating that extracted LLM data, increased interest in human-in-the-loop approaches, AI-assisted transportability of models, like from US to UK. NICE has a really cool project testing transportability aided by AI, and automation of SLRs towards these living approaches. And then the last area that I'll say, I would argue is related to precision. It's about broadening our definition of value or our understanding of value. And the reason why I think that is because if you really want to know the value of the treatment, then you have to understand what the measures are that are actually relevant to that decision. Not just the regulator, not just the HJ, but also the patient. And many of those measures may not be in the healthcare system. They might be in the social community service system. They might be in the employment system. They might be in the correction system for something, let's say, like schizophrenia, where recidivism is a problem. So I won't go through this entire list. I do want to spend my final couple of minutes going a little bit deeper into expanded measures of value. This is the #1 and most ambitious scientific frontier that ISPOR has ever had. And it's also very controversial. So why is this, first of all, what is it? And then why is it controversial? So I'll spend a couple slides on this and then we'll close with some Q&A. Well, what is it? So we conceptualize a whole health approach to value assessment as one that recognizes physical, behavioral, socioeconomic, environmental, and spiritual dimensions of health. It prioritizes enhancing health outcomes that matter to individuals while promoting well-being for all. It's very broad. And by the way, this is a straw man definition. This is not from our Health Science Policy Council. It's just a thought piece that we put out last year in Value in Health. So it is broad, but it acknowledges that health is not just about physical health, and it's not just about behavioral health. It's about the socioeconomic, environmental, and other contexts that are required for someone to get better. And it's also about the recognition that interventions may lie in other sectors outside of healthcare that can actually shape health. I was talking to David earlier today, one of the students here, and he's working on, housing testing for radon as a, predictor of lung cancer in Canada, right? To me, that's exactly whole health. A housing intervention, wow. That's exactly where we need to go to make better use of our science, right? We need to think not just in healthcare, but also think about where there's value to improve health outside of healthcare. So we're on a journey. Our journey is to take core HEOR, which is our current audience. Disease is the driver. It's largely focused on biomedical innovation, the new fancy products. And we need to expand this out towards measuring the disease treated in the healthcare system. Here we get into things like value-based healthcare, implementation science. And then beyond that, there's the societal view of things, which is where health is the driver, not health care. And here we start getting into more things that are a little bit distant from our science now, but relevant, such as interventions that exist outside of the healthcare sector, such as understanding the linkage between environment and health, such as things like understanding community services and health, et cetera. So this is a big and controversial agenda for us. It's controversial because there are challenges. The first major challenge that we have is that we don't really measure cross-sector benefits and costs now. When you think about cost effectiveness analysis as one example, cost per quality, its beauty is that it's standardized and that you can compare treatment to treatment using it. But once you start introducing measuring costs and benefits outside of healthcare, cost per quality, frankly, is not as relevant anymore. You know, we need different measures. We can sure we could actually just keep adding expanded outcome measures, like let's say from other sectors, like educational attainment for kids with ADHD. But if you do that, you also need to think about the cost implications of those other sectors. So this is a fundamental challenge in kind of bridging the gap between where the outcome side of the science is and the health economic side. The outcome side is there. The outcome side is like, of course we need to measure these extended benefits. They get it. The health economic side is saying, well, wait a minute, how are we going to measure value? Because it's too hard to get at the costs in these other sectors. Identifying the right evidence for the right stakeholder becomes a challenge. Right now, we know a lot of our evidence is pointed towards HTA and payers. What is it in the whole health world? Could be the Ministry of Health, could be the Ministry of Finance. You know, the stakeholder that you're presenting the evidence for actually is going to change. And there's probably going to be multiple layers of evidence for multiple stakeholders. It needs to be transdisciplinary, of course, because this is a broad agenda. No surprise there. And ensuring that patients have a voice in all this is something we all have to stay committed to. I think this is part of the easier part, actually, of whole health, because patients understand what drives their health outside of the healthcare sector. But we need them to have a voice in determining how value is defined in this whole health world, so that they help to inform, you know, what measures we're actually using, which lends a lot of support to the work that's going on here in patient preferences. And then there's, of course, the threat of attrition of evidence standardization. You know, what happens when you move away from sort of the standard package of evidence that HTA authorities use right now? Will it disrupt our ability to truly understand the, you know, relative costs and benefits of the intervention versus others? So that was a lot. I know we only have a few minutes for questions. I will be here as well in the reception and would be happy to talk one-on-one. So where's Sandeep?
Yes, I'm here. Sorry for sharing it.
Okay, Sandeep.
Yeah, so feel free to ask. So the person will talk, and first, we'll take the opportunity to ask questions from the people.
Yeah. Yes, please.
Hello, thank you very much for your inspiring presentation. I'm an outsider to health, but I'm interested in your phrase, science is good. And I'm wondering how your method, again, I'm speaking a very elementary basis, captures the bad activity of some scientists. Misstating outcomes of their research, whether because they're in a conflict of interest on the sort of state,
Yeah.
or because they're driven by ideology. But those misbehaviors are salient right now.
Yeah.
Because, for example, U.S. Secretary Bolton is using that type of misinformation to justify this reputation.
Yeah. Well, it's interesting. I was talking to Dr. Marshall a bit at our walk over to here from the other building. I think that what is often not known about science is that it's all about debate. It's all about disagreement. It's all about dialogue. You can't develop new methods and you can't refine those methods and implement them unless you allow opposing views to be heard. And I think aside from the basics, like maybe conflict of interest rules not being quite as clear or as adhered to, I think that this whole idea of being more intentional with allowing dissent is something that we need to do to increase our trust. So the question becomes, how do we do that? Well, for an org like ISPOR, we do it in a few ways. First of all, if you don't support what was published in one of our journals, write an opposing opinion, write a commentary, an editorial, etc. Present it at one of our conferences. You know, we love juicy conversations, believe me. And so, you know, I think promoting the true spirit of debate, which science is supposed to be, instead of saying, you know, we have the answer, we know the answer. Well, you know, maybe we don't always know the answer. We think we know the answer, but someone else may come out with a different answer or, you know, a different view. So I think if we can remain intentional about supporting that spirit of debate, it effectively also helps us to be more trusted as a discipline. And then the other part of this is transparency, and I touched upon this a lot. Transparency is something we absolutely have to stay committed to through protocol registration, using GitHub and let's say public, you know, sources to post your code, badging for studies like I mentioned. We need to make our research sort of as accessible as possible, so that if someone else wants to reproduce it or try to, you know, answer the same question you did, that they can try. Transparency and trust are absolutely connected fundamentally. And that's why we also have a registry. We have a real world evidence registry that we have with ISPI. It's free. So that's another thing that we're doing. Yeah, I don't know. I know it's complicated. I hope that helped a little.
So you were talking about transparency, but also adopting AI. How do you reconcile those two things when AI is notoriously a black box? And even if making sure was to say prompts for AI, it would change depending on the user. There lacks reproducibility there.
Yep.
How do you reconcile those two?
Oh boy.
HEOR goals?
Yeah, you open Pandora's box with that one. So, all right. Our policy regarding AI now in our content is that you can use it, but you have to disclose it. And if you use it, you have to state how. This is supported by, for our journals, it's supported by Elsevier, our publisher. That's kind of like a standard policy they have. But the bigger question is, if it is used, how do you know it's accurate and you can trust it? To that end, what we're trying to do is promote human in the loop approaches. Now, obviously, when you start thinking about the vastness of HEOR methods, like you've got modeling, you've got SLRs, yada, 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 where do you start with the human in the loop approaches? And then even if you do them, how do you know people are adhering to them? But nonetheless, we have ventured into this territory. Our first task force on this is on the use of AI to do systematic lit reviews. And it's going to recommend basically, you know, at what points in the process there should be a human in the loop. In other words, don't just accept when you get the articles that are pulled out based on the title search that that's correct. Like you actually have to inspect what it's recommending. And by the way, AI tosses out a lot of articles that you know, probably would consider relevant. So look at what it's discarding and maybe fish it out. Same thing for the full text part of an SLR. So that's kind of our first foray into it. I think modeling is probably going to be our next foray. We'll have a couple sessions on this topic. Jaime Caro, who's on our HSPC, is going to lead one, you know, about the confluence of AI and models. But it is an ongoing problem, and we often don't know how to enforce it. I guess that's pretty much all I can say about it at this point. Yes.
I'm curious about your thoughts about values and metrics across different levels. So if you have a patient and a physician and they're making decisions, co-making decisions based on a specific outcome, that may counter sort of the benefits.
Yeah.
Or cost, it might not be cost effective, but for that individual, they find the best outcome. And I'm just curious how, you know, when communicating across these levels, how do you engage with the patient or the physician around certain decisions that, you know, may or may not be optimal at different levels.
Yeah. Well, so value is in the eye of the beholder, basically. And it's probably one of the reasons why ISPOR hasn't ventured much into the value-based healthcare space because, like you said, the value as defined in the healthcare system probably is not much aligned with, or somewhat aligned with maybe what HTA would be interested in, or regulator is even separate. Um, I don't think that that's bad. I think that we have to acknowledge the fact that there are definitions of value, and our job as scientists is to inform those stakeholders, not just HTA, but others, with the measures of value that are relevant to them. So I think it's fine if you have one measurement of value that's more for the healthcare provider setting and another based on HGA, et cetera. We're seeing now even higher at the societal level, macroeconomic models targeting ministries of health, looking at, let's say, investment in breast cancer medications. What's the labor force implications and productivity savings? So there's another layer. So can they be at odds? Yes. Is that a problem that it's our job to solve? Probably no. I think our job is to produce the best science and acknowledge that there's different audiences for that science. Yeah. Sam?
What about the importance of evidence, of producing evidence science that's useful for the stakeholders, right? And policy, for example, and the use case, right?
Yeah.
So what's the role of ISPOR in, especially talking about the global piece as well, and then there's the regional or local, and then global. So what's the role of ISPOR in promoting that science for policy change?
Yeah.
And actionability.
Okay, so there's an old way and a new way, and they coexist right now. The old way is that we do roundtables, regional roundtables, with HTA authorities and also with patient representatives. And they actually dictate what issues they would like to put on the agenda, but it's all about HEOR in one way, shape, or form. The new way is that increasingly we're moving towards global roundtables. So this year, we're not doing any regional HTA roundtables. For the first time, we're only doing a global roundtable, mostly because we feel that there's enough advancement of HTA worldwide that the more advanced countries have an opportunity to shape and inform the less advanced countries. That dialogue can happen now. 5, 10 years ago, it couldn't happen because certain regions were just in such a different place with HTA capacity building. But nowadays, there's over 100 countries that have some form of HTA. It may be one guy sitting in a back office, but he's evaluating the evidence. So that's one way. And then the other way is that we have recently started an ISPOR Institute for Healthcare Transformation, which is a department within ISPOR, but is about, I'll call it, amplifying the science, supporting the science. We are still sort of shaking out the agenda of this group and how it's going to be complementary to the existing member operation, so to speak. But in an essence, it'll be about communicating our, let's say, science to different audiences, like sort of repackaging some of our products and deliverables, content products. It'll be about engaging more intentionally with policymakers, like proactively. Right now we've only done reactively. The guidance comes out from EMA and we mobilize members and we build comments. We have a policy director who just started. So far, she's had her hands full with this international reference pricing debacle. But as you can imagine, the sky's the limit in terms of what might be the next focus for her. And increasingly, she'll need to think outside of US and North America. So I would say there's building blocks that are aimed at being more intentional and proactive as opposed to reactive, which is what we were doing before. Yes, howdy doody.
Yeah, I was gonna say, because I probably do, I can't remember the name from the broadened, health and, the new initiative.
Whole health?
One Health?
Whole health.
Whole Health, yeah. That's how we do it. I can't remember things now. But when you were talking about that, I was sort of thinking about, so we've got, in health economics, we sort of focus on
Sure.
quality, and now what you're talking about seems to me that part of the way forward then about that is actually drawing our lens up a bit and going back to where health economics came from.
Exactly. I know. Right.
How does that fit into broadening the tent and bringing in that broader group of experts?
It's like welfare economics versus extra welfareism. And yes, but some of the tools already exist in that pre-world, like cost benefit analysis is one where you can look cross sector. And by the way, in certain types of health services research, like program evaluation, cost benefit analysis is still used. So we have like renewed interest, actually led by Nance Devlin, who's our editor in chief for Value and Health, in cost benefit analysis. They're doing a themed issue on applying cost benefit analysis to whole health. To showcase like, hey, that tool exists. And then there's other methods like contingent valuation, DCE, where you can monetize the value of outcomes and costs cross sector. So some of these tools do exist, but I think what you're getting at is more like, hey, great that you're going in this direction, but it took us a long time to get us here to this standardized approach. And that is a common thing I hear. I would argue that just because it took us a long way to get here doesn't mean that we should stay here. And a lot of my reasoning, it doesn't have, okay, ISPOR has its own agenda with whole health. It's in our strategic plan. But my reasoning is that, I mean, part of it is I'm trained as a pharmacist originally, and I know that patients don't get better unless you consider the holistic context of their situation. And so to me, this is like so obvious, right? It's like the right thing to do. But from a scientific standpoint, I think the reality is that we're going to continue to see an increasing number of real world data sets. And not all of them are going to be in the healthcare sector. We're going to start seeing data sets from the education sector, its environment, et cetera. And that increasingly we'll be able to link those. So we can either keep going like we're going down this traditional route, which does have the benefit of kind of the know-how and the standardization we've developed, or we can acknowledge like, my goodness, if we don't start bringing in these broader dimensions of value, who will? Will IT people just take this over? And then I will add that, from a patient perspective, it's the right thing to do, right? That, patients care about these broader elements. So, and it's so interesting because in some ways, I feel like the patient movement globally, which is real, is kind of at odds with the standardized approaches that we've developed. And I almost feel like there could be a clash coming at some point. Maybe the clash has already been happening and I didn't know it. But I think that there's some tension there that has not fully surfaced between what the patients want and what that means for reducing our standardization in HTA. Do you have any final comments, Deborah? I'm sure you have a lot of thoughts.
Great point.
Yeah.
Yeah, I think it's fair to say there's a lot happening. It's a very exciting area to be in right now. And for those of us who work in preferences or in health economics, I was saying last night, there's quite a large debate coming up about, qualities. Again, these comes up about every 30 years or so. But I really think I'm very excited about some advancements in methods, different methods, thinking about, is it in fact health that we want to maximize? How do you define health? And how do you think about other metrics, ways, methods to apply in a broader way of thinking? And to me, this is exactly how I forgot I was supposed to be on a leash and not stay away from the, thank you.
No, there's
Uh,
anybody left online.
Yeah, well, I don't know. But at any rate, I do think it's a very exciting time. And I think also for our young people in early career research, there's some fabulous opportunities to think a little differently and outside of the box, if I could use that expression. So I think I just wrap up today, and thanks very much to Dr. Pizzi to traveling up to visit us and join us and share some of the thoughts at ISPOR, and maybe it will stimulate some ideas for you and provide opportunities for connections that maybe you didn't have before, opportunities to reach out and explore, and continue to keep thinking and doing the hard science. I do feel extremely strongly, which is part of my role, or the reason why I did agree to take on the role for Health Science Policy Council, that we must stick to the science, and reproducibility is critical. And you mentioned that we need to have the transparency and the reproducibility in science, and always challenge. It's like when we have conversations with our students, always ask the question, because sometimes we do things because that's the way we do them. And I think we as a scientific community need to keep challenging. There isn't a right or wrong. I hope we keep evolving. So go out there, please evolve. And I would say thank you to Dr. Laura Pizzi. And I have a little small gift for you.
I feel like I've already
From
been
the
so
mountain.
spoiled.
They're very, very eco-friendly. Yes, by the way, paper, completely recyclable, Rocky Mountain, et cetera. So thank you so much.
Thank you. I appreciate
I
it.
really appreciate you coming and
Welcome.
spending
Thank
this
you,
time.
everyone. It's been great. Should I open it or is it a secret?
Up to you. I don't think you'll be embarrassed. It's a basic, but as you wish. But I think most people in Calgary would know Rocky Mountain Soap Company is pretty famous here. It's sustainable, everything's recyclable, and all of that. So thank you for coming, and thank you everybody for joining us.